Okay, we'll talk a little bit about analyzing the latent image, looking at the image that results and determining what we did well, what we did not so well, and ways to improve our pictures. So this really is kind of the evaluation piece. We've now got enough learning, we've defined enough terms, we've considered enough concepts to kind of tie it all together. And so this lecture really is one of the reasons why I'm saying for that final we need to be good with both our learning in the last trimester and our learning in this trimester, because it all connects in this one key concept, as well as with what we're looking at next week. So here's 4 learning objectives related to this. We need to list variables affecting exposure, subject contrast, noise, sharpness, magnification, and shape distortion on the image receptor. And you'll notice that looks very similar to the ART content specifications, that table, right? Remember that awful table that we whiteboarded about? Like what happens if you increase mass, what happens to the image, right? What happens if you increase KVP, what happens to the image? Define resolution, the geometric aspects of the image to include both spatial and contrast resolution. Explain purposes of measuring spatial frequency and the MTF, modulation transfer function. And it's not going away. That stuff we will come back to when we talk about digital imaging, which I've said is kind of like image production 3, but those are key concepts to the digital image evaluation. And then finally, we will talk about limiting factors of the digital system, things that digital doesn't do well. So, exposure. We've defined exposure really carefully now. In fact, the last lab that we did, so everyone's done the half value layer lab at this point, right? And we all kind of should have some idea in the back of our minds what we're talking about when we talk about exposure, right? But it's the quantity is the way that generally people mention this, the quantity of ionization that's occurring, right? The amount is the exposure. So what affects the amount of ionization that's occurring inside of the patient's body, right? Mass is the very first thing that pops into my mind. When I think about exposure, another term that's used interchangeably with this is intensity, right? Intensity, quantity, exposure, all of those words. The main thing that we use as a technologist to influence that intensity or exposure is the mass, the milliamperage seconds. So we've broken that down into a formula. We've worked that formula backwards and front, and what we've said it is directly proportional to exposure. So looking at these 2 images here, if we said that we didn't mess with the window level, maybe these were even film images, not digital images, which of these 2 images has the higher mass? The one on the right. It has the more darkening, right? And so that's one way that sometimes in the past, especially on film, we would talk about the amount of density that was on the image. And what we meant by that was the amount of darkening on the image, right? The amount of black on the image. The other image has more white on it, and so we would say it's less dense, right? It's less dense. It did not have quite enough mass. The way that we generally talk about it now in digital is kind of the reverse of that. We talk about brightness. So if I ask the same question, well, it sounds like the same question, but it's changed a little bit. Which of these images is more bright, right? It's the one on the left, right? That means it has a decreased amount of mass. So again, directly proportional, 2 different ways to ask the same thing. KVP does some weird stuff, which we've established. We have to use that 15% rule. Why? Because KVP has an exponential effect on exposure. So we should have, some of us had kind of an aha moment around KVP by now, hopefully, or we're working towards an aha moment with KVP. And when one of the things that I'm saying is, interestingly enough, KVP affects exposure even more than mass. KVP affects exposure even more than mass, right? So it is more difficult to fine-tune something using KVP, right? It's more difficult to fine-tune it. So how do we do our fine-tuning? We do it with mass because it's directly proportional. KVP, if we really want to just max something out, like that picture from Reddit of the soda pop, right? Got max KVP, max mass to get through a morbidly obese patient, right? Interestingly enough, KVP does some weird stuff, right? And so we've kind of dug around and tried to really understand what KVP is doing. But what, kind of looking forward towards next trimester and safety, what happens to patient dose as KVP increases? It decreases. That's kind of weird, right? Because all of those photons now are just shooting straight through the patient, right? So it does have its limitations. KVP, though, has an exponential effect to exposure. The generator in the rectifier system that we're using affects exposure as we increase from a single phase. If we're shooting in that small room and we jump over to the larger room, we can actually reduce our technique, right? Because the larger room has a high frequency generator and the smaller room has a single phase generator, right? So it is a less efficient way of producing exposure. Protective filtration should have no effect on exposure. Why? Why? We looked at the half value layer last time we were in the lab. Why would we say that protective filtration should have no effect on exposure? What's protective filtration getting rid of? The low energy, the trash x-rays, right? The stuff that would just hit the patient's skin, ionize the skin, give them skin cancer, but in no way contribute to the image. So protective filtration, no effect on exposure. It's just there getting rid of a skin exposure. Field size. What happens as we increase the field size? What happens to exposure? It increases a lot, right? Because not only now are we getting all of the x-rays from the patient, the remnant beam, we're also getting scatter. As we increase that field size, we're getting scatter. So that scatter is increasing the amount of exposure at the image receptor, right? Grid usage. What happens if I increase my grid value? What happens to exposure? Careful. Grid does affect exposure. If I increase from a 5x1 grid to a 12x1 grid, what will happen to exposure if I don't make any changes to my technique? It will significantly decrease, right? So we've had to do things like apply Bucky factors, right, to compensate for grid usage. Grid is going to give us better what? If we use a grid, we'll get better contrast, right? But we'll have to increase patient dose and increase mass to compensate for all the stuff that we filtered out, all the scatter that we're getting rid of, all the scatter we're cleaning up. Finally, anode heel effect is just weird. It does something weird, and we talked about that last week, where it makes a non-uniform exposure field. So there's a part that's hotter on the cathode side, but on the anode side, it's a little bit cooler. So it's not as uniform a field of exposure because some of the x-rays have been attenuated by the anode itself. Inverse square law is the way that we talk about SID's effect on exposure. And this is one of those ones that you can just demonstrate at home with a flashlight, right? That as the flashlight gets closer and closer to the countertop or what have you, it gets brighter and brighter. The intensity increases and increases. So the exposure there is increasing as well. And then finally, OID. What's the deal with OID and exposure? What happens as we increase OID? What happens to exposure? It decreases, and that's what we're talking about when we talk about an air gap technique. What decreases is the amount of scatter reaching the image receptor. And so there's a decrease in exposure due to some of the scatter bouncing off in a funny direction and not striking the image receptor. So we call that an air gap technique. We can use it essentially like a grid to improve contrast. So you notice we just spent a lot of time on that one slide, and we had to walk through every single thing that we've talked about for the last, 5 months, 4 months? It's a lot. It's a lot. Just saying the word exposure as an X-ray tech, there's a whole lot of factors that I'm kind of thinking about, right? And they're pretty straightforward. Most of those are fairly straightforward. Subject contrast, I feel like it's the one that we struggle with the most as students, right? It's the one that I struggle with the most. In teaching it, it's also difficult to teach. So I wanted to give you all this image so that you can see the distinction that we're talking about. These images, if we were seeing them on a high-def screen, we would say that they have essentially the same amount of exposure. And the reason I can say that is because I can see about the same amount of spine through the shadow of the heart. There's other ways that I could measure that. Like I could say we have roughly the same amount of density in the area of the lungs. But one of the easiest ways to determine if the exposure is about the same is to look at the T-spine through the heart, right? It's a good measure. But they differ in their amount of contrast. We have a high contrast image where there's a big step off between the darkest parts of the image and the brightest parts of the image, versus this other image which has a lot of different shades of gray, right? It has a lot of different shades of gray, so we will call that low contrast. So a lot of times the way that we talk about this is that the one on the left has what we call a short scale of contrast, and the one on the right has a long scale of contrast. And that's the other thing I like about this picture. If you look closely at it, it has the scale of contrast next to the image, right? It has that little scale. There's a step wedge scale. And so let me zoom in real quick on the high contrast one. You can see there's not that many steps to go from dark to white. We went there in pretty much, 6 steps from dark to white. Over here, how many steps did it take? About 10 steps. So we are calling that a long scale of contrast because it took more steps to get from dark to light. So just a different way to talk about a subject contrast with some detail. So what are the variables that affect subject contrast at the level of the image receptor? So we have said that largely KVP is critical to contrast. That as KVP increases, what happens to contrast? It decreases, right? And then as we decrease KVP, we wind up increasing contrast. So on these two images, let me zoom out again. Which one of these would we guess has a high contrast?
Right. The one on the left that says high contrast.
So I'm asking for what did I ask the wrong question?
Yeah, I think so.
High KVP. Which one of these images has a high KVP? The one on the right. The low contrast image has a high KVP, right? And so conversely, the one on the left is a low KVP image because it is a high contrast image. That is a weird way of thinking, right? And it constantly trips me up. I constantly have to remind myself of it. So did I just lose anyone on that one thing? Okay, good. Let me pause. But I think that y'all are doing well. We're getting a grasp on this. All right. Well, in a similar way, the generator has some influence on contrast because the generator affects that average KVP. Like what we talked about with the half value layer, the exact same thing is happening with our generator. So remember what happened to our curve as we increase the amount of filtration. I'm going to draw that on here real quick so that we can see this as we're tracking along online. So if we've got over here, if we're going to draw a curve of just Bremsstrahlung X-ray interactions, right, that are kind of exiting the tube, if you will. I've said the curve kind of goes up and then it tapers off. So let's say our KVP is, what should our KVP be? I don't care. 80. That's what we did in the lab, at least, was 80, right? So this is the number of photons, and this here is the energy, right? The amount of penetration, which is what we're talking about when we talk about KVP, right? The amount of penetration, the quality. These are terms that can be used interchangeably. The quality, the penetrability or the penetration, right? The energy of the beam. Now, one thing that doesn't work really well in the analogy that I used earlier is they're not running any faster. They have a higher frequency, but they're all going the speed of light, right? They're higher energy, okay? Now, let's go over here and draw the same thing, right? But we're going to add some filtration to it. Or we could say in the same way, we're going to mess with the generator. What we're going to see is a shift in where that peak lies. So if the peak was here versus the peak was there, the peak is roughly a third on this one, a third of 80 kVp, and this one's about half of 80 kVp, right? So the same thing kind of happens as we increase generator. The average KVP, the average energy increased. The average energy increased. So there's a subtle difference in those curves, marking that the average energy has increased. And so that difference in those curves would translate to these differences in these images below, right? That the generator that produces the higher average energy is going to result in a lower contrast image, right? All right, protective filtration, again, no effect. If you're wondering where I'm getting these things from, they're both in the textbook and in that ARRT content specs. The field size, what happens as I increase my field size to contrast? It decreases, right? And what's causing that decrease in contrast? Scatter radiation. Good. Good. Part thickness. As part thickness increases, right, the contrast is going to decrease, right? Because I've got more and more scatter occurring inside of the patient. More and more scatter being produced by that additional part thickness. Patient conditions create variations in contrast. Can we kind of picture what it would look like if, for example, our patient had pneumonia and we're doing a chest x-ray? That pneumonia would result in a lower contrast image, right? Because there would be those kind of opacities or those densities throughout the image, right? Other things like emphysema can wind up causing a higher contrast image. So one of the things we're going to be looking at, kind of a continuation of the conversation, is this fall in comparative pathology, considering how pathology is affecting the image, right? That doesn't look normal. The contrast looks funny. Is that something with the technique that I used, or is that something with the pathology that's apparent on the image? So sometimes there's hints there. We've already mentioned scatter radiation and its effect on contrast. Anytime we see an increase in scatter, so things tied to the increase in scatter will cause a decrease in contrast. What happens with grid usage? What did we say earlier grid usage does to contrast? It improves the contrast. It increases the contrast, right? But it does it at the expense of patient dose. Honestly, I think if there's going to be a change in the course of your lifetime as a technologist, it will probably be that we move away completely from the use of grids. I think that digital technology will eventually be able to do everything that grids are doing. It'll be able to clean up the picture for us, and we won't be using grids anymore. But for the time being, grids are a necessary evil. We still have to talk about them. All right, well, let's talk about image noise, right? Image noise, for the most part, has to do with insufficient mass. So if I do not have enough mass, what results is quantum models. So on these images here, the one marked A, the one on the left, has a lot of quantum model, right? Hint, hint, you might want to mention this as you're working on your essays, right? Because it's there, it's apparent on the image, and there's even some stuff on the picture that will give you additional support for that, right? When we have insufficient KVP, that can make a quantum model even more apparent. But interestingly enough, excessive KVP produces more scatter, right? So if we have too much KVP, we start to produce nothing but scatter. There is what we call a diagnostic range of energies, right? And then beyond that diagnostic range of energies, we have a therapeutic range of energies. That's important. The diagnostic range of energies are those energies at which we can still have the photoelectric effect. The diagnostic range of energies are those energies of X-rays at which the photoelectric effect can still occur. As we start to get higher and higher in our KVP, eventually we have a huge fall off in photoelectric effect, and all that we have remaining is Compton scatter. And we are no longer within a diagnostic range of energies. As we increase the field size, noise increases because we've said that scatter increases. So I want to point out two things. On this slide, we're really talking about two different forms of noise. One is quantum model, which results from insufficient mass, right? It's just a graininess on the image. The other form of noise that we're talking about is scatter. They are two different things. As part thickness increases, we see an increase in noise, right? As certain patient conditions increase, we have an increase in noise, right? So again, going back to our earlier example with pneumonia, as it increases, the amount of pneumonia in the lungs can increase the amount of noise because it's increasing density, which would increase scatter. It'd be a very subtle change, but it would. Grids reduce scatter, so they get rid of noise, but if we don't use them correctly, they can create an artifact. So sometimes texts call it shark bite or a moire artifact. We'll return to that when we talk about digital imaging and how that artifact results from grid usage. And it's one of the main things against grid usage. When I say that I think that grids are going to go out of style in the course of your life as a tech, it's two things: the artifacts that can result from grids and the increased patient dose. Those are pretty strong points against their use. If we increase the OID, we can decrease the scatter. So that's, again, that air gap technique. That increased OID can decrease noise. And then finally, to talk about things independent of technique, motion can generate artifacts, right? So it's a geometrical kind of noise, the motion artifact. Okay, sharpness of detail. Focal spot size is going to be the primary way that we control sharpness of detail. And we've really stressed on the last lecture and this one as well that the focal spot size is not in any way tied to technique, right? The significant thing to consider with focal spot size is the tube heat units. How much heat can we withstand at the smaller focal spot size? But it's going to be the primary way that we control sharpness. So if we said that these two pictures here had essentially the same technique, which honestly they don't, but if they did, which one would have the smaller focal spot size? The one on the right would have the smaller focal spot size. It has more sharpness on it. Anode bevel can affect what we call the projected focal spot size or the effective focal spot size, right? So we sketched that out. We looked at that picture of the textbook where we looked at how we were basically doing a bank shot as a way to produce a smaller focal spot size. Sod over oid controls sharpness, so that is the way that we calculate on sharpness. Motion can cause blur, which is a reduction in sharpness of detail. So I've said that motion kind of sits in that funny place between geometry or sharpness and noise. But probably the best way to talk about it is the blur that it causes an unsharpness on the image. And exposure time can affect sharpness by giving additional time for someone to move. This is particularly true in pediatric imaging. When we're up in the NICU, we want to use as small a exposure time as possible because the patients are really uncooperative, right? They don't even know what cooperating means. Magnification. So now we are over on the end of pure geometry, right? We're just talking about geometrical factors and how they influence the picture. And so the ratio that we talk about is SID over SOD. That this is the way that we control magnification. We increase our SID and decrease our OID. And so control the amount of magnification. So the image on the right is clearly more magnified, and the reason we can say it's magnified is because it's uniformly enlarged. There's not one part of it that's more enlarged than the other. So this is an increased OID. So positioning can influence this, right? So there's ways that we actually use magnification to our benefit. One of the great examples of that is a PA chest x-ray. What has an increased OID on a PA chest x-ray that we might not want superimposing other things? The heart's actually closer, but what's further away is the thoracic spine, right? When I'm doing a PA chest x-ray, I'm not interested at all in the thoracic spine. So I've positioned it further away from the image receptor and in a sense magnified it out. Magnified it out so there's less detail there on the thoracic spine, more detail with the heart, right? If I was wanting to see the thoracic spine, I would have the patient positioned for an AP projection, right? Just be really careful when we use those terms. The registry is very specific that AP and PA relate to the projection. Positioning terms are things like oblique, right? Or supine. All right, shape distortion. There's always a little bit of distortion on pretty much everything that we do. Sometimes it's more apparent than others, right? But the alignment of the beam, the part, and the image receptor are the primary ways that we can control for shape distortion. So for the most part, we want the central ray to be perpendicular to the part and also perpendicular to the image receptor. Right? Anytime that there's something that's not perpendicular, then we wind up getting some form of distortion. So if A is an undistorted image of the humerus, B is what we would call foreshortened, and C is what we would call elongated. So here's the trick question. What is out of whack on which? Right? So A, we've said everything's perpendicular. The central ray is perpendicular to the humerus and also perpendicular to the image receptor. What's going on with B? What's not perpendicular with B?
The body part.
The humerus, correct. The humerus is not perpendicular. The central ray is perpendicular to the image receptor, but the humerus is at a funky angle. So that kind of gives us what the answer is for C, right? That in the case of elongation like this, the central ray is perpendicular to the humerus, but not perpendicular to the image receptor. This is really crazy, confusing stuff, y'all, right? I mean, this is a lot of detail. Is this what you thought you were getting yourself into when you signed up for X-ray tech school? We're now officially at depth, right? I mean, we're at that point in y'all's career where I start looking at y'all as equals. I've taught you just about everything that I know on this subject. I mean, there's some fine stuff that we still need to go over with safety and with digital, but you have a lot of the tools that I have to make better pictures, right? How you apply this in the clinical setting is what's critical. So I'm giving you all the definitions today, right, and kind of breaking this down as much as possible. resolution. Now, if there is a number 2 most confusing thing to us as students, it is probably resolution. So contrast, I've said, is probably the number 1. Resolution's a close second. We've got 2 forms of resolution that we can consider. And the way that I define resolution, I'm trying to make this as simple as possible, is the ability to distinguish the individual parts of the object. I can say that's one part and that's a different part. Spatial resolution is the ability to distinguish tiny objects. Sometimes it is called high contrast resolution because it is these tiny high contrast objects that we are differentiating. So this is measured by spatial frequency, which is expressed in line pairs per millimeter, right? And I've offered some examples from the textbook of what that measurement looks like. Just know that we've talked about it in the past. We'll continue to talk about it. Anything that affects, right, the geometry of the image, the sharpness of the image, has an effect on the spatial resolution, right? So everything that we were talking about earlier that affect sharpness of detail was affecting the spatial resolution, sometimes also called high contrast resolution. Versus contrast resolution, aka low contrast resolution, is the ability to distinguish objects with a similar density, right? So going back over the slides, if I think about be able to differentiate between the heart and the thoracic spine, they have similar densities on the image, right? So can I differentiate between them? I would call that a contrast resolution. This is measured by a modulation transfer function. Sometimes that's abbreviated MTF, right? And it's expressed as a number less than 1 but greater than 0. So it's in a range of 0 to 1, right? The higher being the better. So let's look at some concrete examples of this. So with spatial resolution, we're talking about the smallest object size that can be reproduced, right? And it's going to be equal to basically 1/2 the spatial frequency. So let me zoom in and show you what I'm talking about. As I zoom in here, I'm going to look at this line thing here, right? These little tiny lines have a high contrast. There's white lines and then there's black lines, right? So this device was x-rayed, right? And as I get closer and closer, in fact, we can see an artifact here. Do you see that kind of funny magic eye, kind of these folds here? Like there's a fold, there's a fold, there's a fold, there's a fold. You see those little things? Those don't really exist. That's an artifact. That's not there on the object, right? But what we're seeing is as we get smaller and smaller and smaller, right? Like down to this area, can we see any of the lines anymore? No. So our line pairs per millimeter, it's difficult to say for sure, but there's that line pair per millimeter measurement right there, right? It's somewhere in this range right here, right? 1.5 line pairs per millimeter, right? So in terms of knowing what the spatial resolution is of this foot x-ray, when we're looking at these little tiny trabecular details, all these bony details in the foot, in the bones of the foot, what we know is that the smallest thing that we can see is 1/2 of 1 over 1.5. 1/2 of 1 over 1.5. That's the smallest thing that we can see. Why is that the case? Because it is a line pair. It's a line pair. So the line pair includes both the white line and the black line. So half that is what we can see. I was able to see a white line, right? Which is half of the line pair. So that is the smallest size that I can see, is 1/2 the line pair, or a black line, right? So we use this line pair resolution test pattern to determine what the spatial resolution of the imaging system is, right? And the focal spot size is the primary limiting factor for spatial resolution, for the most part. That says FFS. I think it should say FSS. Sorry, a typo there. All right, let's talk about contrast resolution. All right, loss of contrast resolution at the little tiny scale when we zoom in is due to the effects of penumbra or image unsharpness, right? So we're back to that ratio of, what was it, sod over oid, right? That unsharpness way of measuring things. So the MTF will give us various spatial resolutions depending on the object size, and from that we can determine what the contrast resolution must be, right? Digital systems always have a lower spatial resolution but a much higher contrast resolution than film. Digital systems have a lower spatial resolution than film but a much higher contrast resolution. They can make all sorts of determinations of this. So as I look at these lines, right, I mentioned earlier that there was an artifact on the image. I tried to find a picture that didn't have an artifact on it, right? And so with these lines now, what I'm looking at is these lines are actually white and black. That's all that there is white and black. But when I'm looking at this picture, it actually looks like there's some grayness there. I don't actually see a white line, I see a gray line, right? So contrast resolution is looking at the point. So I think right about here, I've still got a white line and a black line. But somewhere right about here, all I've got is a gray line and a black line. Where did that gray line come from? Where did it come from? I said it doesn't really exist in the object. Where it's coming from is it's the penumbra from the black line. It's that unsharpness coming off of the black line, right? That's resulting in this apparent grayness to that line. So these, again, are at the microscopic level, making determinations about how fine can this thing make a determination in contrast. All right, and I do want to point out that a lot of these things were more of a struggle back in the day, as they say, right? When we had light boxes and we were doing film imaging. A lot of it can be corrected for by digital systems, but this is an example. This used to happen even when I worked recently in the OR. Sometimes certain surgeons wanted to have images up on the light box in the OR, right? And what they would do is they would grab a spare film, roll it up, right, in order to better see what a fine detail in an area that might have some low contrast. So they would call it like hot boxing that, right? They would use a bright, they would use this tube, right, to cut off veiling glare from other parts of the picture so they could more clearly see what they wanted to see, right? We don't have to do that anymore, right? Because we can just window and level it digitally. So I say all that to say we are kind of closing the chapter, as it will, on this trimester of discussing image eval. But continue to review these concepts, continue to quiz yourself on it in the clinic, because it's not going away. We're going to open this thing right back up in our discussion of digital imaging, and we'll be starting right over again, talking about spatial resolution and contrast resolution, and how the digital system now plays with those things. Because all we've talked about so far is what's happening at the image receptor. What's happening with that latent image? But does it stay latent? Latent means that it's hidden. No, it is digitally processed now and it results in a digital image, right? So that digital process is the part that we've only begun to talk about. We've defined some terms around.